Okay. And we are live on YouTube. So, good evening, everyone. Good evening, everyone. Good evening as everyone is coming in. Whoa. Okay. I had to stop that. Sorry about that. So good evening, everyone. My name is Shamaya Bird. I am the Dickey Cancer Program Manager at the Cancer Support Center. I just want to welcome everyone as everyone is coming in. I am very delighted to be here with you all this evening and partnering with Chi Lambda chapter of Omega Psi fraternity and presenting you all our prostate cancer and the importance of screening panel discussion tonight. We have some really great panelists who are joining us tonight who have really great informative information to give you all tonight. And so I just extend thanks to our panelists for being here. I extend thanks to you all, our guests, for joining us, taking the time out of your evening for joining us tonight. And I look forward to this discussion. So before we get right in, I just want to give a little bit of Zoom etiquette for everyone. We will have a brief question and answer section towards the end. Kathleen will be keeping up with our questions and answers. So we do ask that you all put, like, when you drop in your questions in the chat, put the doctor, or we do have a survivor on the panelists as well. So you can either put the survivor or the doctor. And we have an educator. So either or, put their names before the question and then the question, so we know who to address to. Or if it's just a general question, you don't have to address it to anyone. So those are the questions. And yeah, without further ado, we can get right into our program. So, 1 minute. Okay. So our first panelist is Dr. Rasul Dickey. Dr. Rasul Dickey was born and raised in the Chicagoland area and attended Rich East High School in Park Forest, Illinois. Rasul continued his education at Xavier University of Louisiana, where he earned a Bachelor of Science in Biology and Doctor of Pharmacy degree in 2006. Dr. Dickey is currently a specialty pharmacist for Caremark. He currently works with patients who have been diagnosed with disease states such as cancer, multiple sclerosis, pulmonary arterial hypertension, and HIV, amongst others. He previously was a community pharmacist for about 13 years in Houston, Texas. So without further ado, we want to welcome Dr. Rasul Dickey.
All right, thank you. First off, I want to thank everybody for the opportunity to do this again. Thank you to the Cancer Support Center. Thank you to my brothers at Chi Lambda chapter of Omega Psi Phi fraternity. Thank you very much. So let's go ahead and get into it. So the first thing I want to talk about is the top leading causes of death amongst minorities, and in particular, African-American men. So the first cause of death usually is going to be heart disease. And this is very important as a pharmacist because unfortunately, a lot of the treatments for prostate cancer can actually interfere with different causes of heart disease, such as hypertension, congestive heart failure, stroke, heart attacks, things of that nature. So I actually picked out just a couple medications that we do pretty frequently here because we have a ton of medications, but we don't have enough time to go through everything, just to kind of show you guys a couple examples of what I mean. The number 2 cause of death, unfortunately, amongst most African-American men is going to be cancer. And the top 3 cancers that African-American men usually suffer from are going to be prostate, lung, and colon cancer. Unfortunately, we are at a higher risk of getting prostate as well as colon cancer. So that's just something to keep in mind. And also, I do want to let a lot of people know that even though a lot of people focus on one cancer, like, a lot of people who have only one cancers, we do have a number of patients who have more, 2 or more types of cancer. So it makes things a little bit harder to treat. And, as a specialty pharmacist, we want to make sure that they have a good quality of life. So it makes it a little bit harder to get that aspect of their life in order as well. So moving on. So usually prostate cancer tumors are fed by testosterone or dihydrotestosterone, which are pretty much the components that make a man. If you didn't have testosterone, you wouldn't have the as the omega say, the alpha mentality that you have. So we have to be careful when treating these disease states to make sure that we don't deplete the levels so low to where the quality of life is not where it should be. And what I want to do is just share a couple of the side effects that we do see commonly with the treatment of androgen suppressing medications. And androgen suppression just means suppression of sex hormones such as testosterone, such as estrogen, things of that sort. So one of the top things we usually see in patients being treated with these medications is sexual dysfunction or reduced sex drive. Testosterone pretty much drives a man's sex drive. If you cut it too low, it's going to cause issues. Why is this important? It's important, because men who can't have sex don't have that outlet of pleasure in life. So sometimes that can lead to depression, but also this condition can affect their relationships, such as, married couples, somebody who's dating, to be somebody who's used to being intimate with their wife, on a consistent basis, and then to be all of a sudden treated with these medications and you're not able to perform can cause a lot of strife within couples, can cause a lot of mental depression as well. And we're not talking about a situation where you can take a Viagra and everything's okay. This is a lot different than that. Another thing that we see a lot in these patients is fatigue. This is an issue because, of course, most people have to go to work if they're of working age. A lot of patients may have to go on disability because they just don't have the energy. And think about what that can cause when you not only have to go on disability, you have reduced pay, but also you're dealing with increased medical bills because you now have this condition to deal with and to pay for. So once again, things like this can cause depression. This is also a big factor for our older gentlemen who may be retired, but maybe they have grandkids that they like to play with on a day-to-day basis. Now, all of a sudden, they don't have the energy. They just don't want to get out of bed. So those type of things are definitely a concern. Also hobbies, such as going to the gym. The thing about prostate cancer is the better healthy that you are, the more health that you have before getting this condition, usually the better you'll fare. Because it can affect different things, such as, like I said before, hypertension. It can raise your blood sugar levels. It can actually raise your cholesterol levels. So optimally, if you're in good shape, you'll be in better shape to fight this condition. So that's one reason why we do consider, why we do push our African-American men to get to the gym, watch their diet, exercise, and things like that. Also, this can cause accelerated muscle weakness or loss of muscle, which is very important because as we age, we already lose muscle. And the older we get, I think they say we lose between 50 to 60% of the muscle that we have when we're younger. So for a younger man who gets this condition, it's going to accelerate that muscle loss. So that's something that we try to keep under control as well. Can also cause weight gain, which is very dangerous in some of our patients who do have diabetes, some of our patients who do have hypertension. Of course, depression. Once again, you lower the testosterone, you add in all of these other effects of sexual dysfunction, fatigue, hot flashes, muscle loss is definitely going to lead to some depression. Also, irritability is a common side effect seen with these medications. And once again, increased cholesterol levels. So I'm just going to go into a couple medications that we use on a regular basis and just tell you some of the side effects and how they're used. One of them is Leuprelide. Leuprelide is an injection. It can be given either sub-Q, which means under the skin, kind of like insulin injections, or it can be given IM, which means into the muscle. Two common medications that we do give are going to be Eligard and Lupron. Eligard's usually into the muscle, Lupron's usually sub-Q. The good thing about this medication is it can last anywhere from 1 to 12 months, meaning that for a lot of men who may not be compliant with taking tablets or pills every day, if their condition allows, they're able to get this injection and they don't have to worry about staying on top of a daily treatment. A lot of women actually take this medication too for things such as endometriosis or fibroids. How it works is it stops the pituitary gland from producing a hormone called luteinizing hormone, which pretty much stops the production of testosterone or decreases the level of testosterone. One good thing about this medication, and this is actually something not to really scare men, but there are men who may have to have their testicles removed due to prostate cancer. And you can only imagine how psychologically damaging that can be to have your testicles removed. But what this medication can do is it can reduce the levels of testosterone so low to where certain men won't have to get their testicles removed. So like psychologically, that issue is not there. But it drives the level of testosterone so low to where it's considered to be chemical castration. Now, going into some of the side effects of this medication, like I was saying, one of the main side effects, 98% of men can get hot flashes. Any woman over 50 can tell you that's not a pleasant condition to have. It can also cause flushing. I don't know if anybody here has had flushing, but if you want to experience it, take a tablet of niacin on an empty stomach and see how that feels. It's not very pleasant. As far as the endocrine and metabolic system, this is where it gets a little bit dangerous. 7 to 59% of patients who take this medication will have increased serum cholesterol. So if you're already taking medications for cholesterol, they're probably not going to work as well. Now your oncologist has to get with your general prac or your cardiologist to try to work on your medications to get those levels evened out. And that's not an easy deal. And usually a pharmacist is kind of in the middle of trying to get that worked out as well. 5 to 32% of patients can have increased serum triglycerides, once again, messing with the cholesterol, decreased libido, and so on. So another danger of using something like this medication is, unfortunately, it can cause a condition called QT prolongation or sudden cardiac death. So this is something that a lot of our patients have to consider as a risk of taking this medication. It's basically a kind of a deadly irregular heartbeat, just something to know about. Also, it is known to cause hyperglycemia, which is, dangerous in diabetic patients. That just means increased blood sugar. So whatever medications you've been on, whether it's metformin or insulin, those levels, once again, have to be readjusted, and it's going to cause issues. Also, depression can also cause psychiatric events such as irritability, impatience, anger, and aggression. Sometimes the medication can also cause what's called tumor flare. Instead of shrinking the tumor, sometimes these can make the tumor grow bigger temporarily. So as you know, you're already trying to fight prostate cancer, you have a bigger tumor, that's going to cause some issues. Seizures have also been seen with this medication, and also decreased bone density. And this is important in our older generation, because as you get older, your bones become less dense. Osteoporosis and things like that are pretty prevalent. So things as a simple fall when on these medications, when before you'll be okay, may cause major damage. So those are all things to consider when dealing with people who are especially older in age. Okay, so moving on to an oral therapy that we do. One is Etiquette. It's very common. It's a CYP17 enzyme inhibitor. Once again, it's just cutting down on testosterone. It is an oral medication, which is positive and negative. It's positive because this medication does have less side effects than some of the other medications. But once again, when you have men who deal with compliance and may not want to take their medication consistently on a daily basis, they may forget. That can be an issue. Once again, this causes less side effects, less sexual dysfunction, less depression, and less agitation. So that's why this medication is pretty popular. Okay, so going into some of the side effects is Itiga, edema, which is pretty much pooling of fluid in parts of the body. Hypertension is seen in 9 to 37% of patients. And when I say these 9 to 37%, these are really high numbers. So say, for instance, you're taking a medication such as Lipitor. Most of the side effects are not going to be above the single digits. Whenever you get into single digits, into double digits of side effect percentages, it's never a good thing. It means that this is a high chance of getting these side effects. Once again, hyperglycemia, which is increased blood sugar, a 57% chance of getting that. Hypernatremia, which is increased sodium in the body, you have a 33% chance. Hypertriglyceridemia, 63%, which is through the roof. Diarrhea, 22%, things of that sort. So pretty much, I'm going to wrap up, but what I want people to know about prostate cancer is that it's a very treatable cancer. However, it does wreak havoc on our community due to the other disease states that we have. It does wreak havoc sometimes on families and things of that sort. So the thing that I'm trying to drive home is whether you get a digital exam, it's not that big of a deal. Whether you get a PSA or a Gleason test, just do what you need to do to get early detection so that you can kind of avoid some of these side effects and things of that nature. But yeah, that's pretty much my time here. Once again, I thank you guys and look forward to your questions.
Thank you, Dr. Russell, for sharing. That was very informative, particularly about the treatments and the side effects. I think that's important for everyone to know, and just your physicians being transparent with you about the side effects. So thank you again, Dr. Russell, for presenting. I just real quickly want to remind everyone to drop questions in the chat. We do have someone keeping up with questions. And I didn't say this in the beginning, but it's a cautionary for everyone. We are recording this for folks to go back and view as well. We will have it on the Cancer Support Center's social media. And we are YouTube live streaming this as well. So I just want to make sure everyone know that. Going into our next presenter, we have Dr. Fulton Porter. Dr. Porter is a specialist in internal medicine and hospital medicine and currently serves as the medical director of the hospitalist program at the Community Hospital in Munster, Indiana. He is a graduate of Morehouse College and Northwestern University Medical School. He served in the U.S. Army and completed residency training in internal medicine at Brooke Army Medical Center at Fort Sam in Houston, Texas. He has served at bases in Georgia, South Carolina, and Kuwait, and was honorably discharged from the U.S. Army, having achieved the rank of major. Dr. Porter has been instructor of medicine at the University of South Carolina School of Medicine, as well as the Northwestern University Feinberg School of Medicine, and is a fellow of the American College of Physicians at the Society of Hospital Medicine. He has also earned a Master of Divinity degree from Seabury Western Theological Seminary and is an ordained Episcopal priest and the pastor of St. Thomas Episcopal Church in Chicago. Dr. Porter is the founder and president of the St. Thomas Community Development Corporation, which is a 501c3 organization whose goal is to create economic, social, and educational opportunities in underserved communities. He serves on the board of Voorhees College, the Renaissance Collaborative, and the Chicago Community Chorus. Without further ado, we're going to welcome Dr. Fulton Porter. And Mr. Porter, if you need to share a presentation, just let us know. I can make you co-host.
Thank you. No, I don't. Hopefully, this will be simple enough that people can take home certain points. But I want to thank my brothers from Chi Lambda Lambda for inviting me to participate in this forum again. And thank you, Cancer Support Center, for supporting and sponsoring this as well. I think this is a very important topic. I appreciate Dr. Dickey's comments before. He scared the hell out of me. And so I appreciate understanding, the drug therapies for prostate cancer. But I think we need to back up just a little bit. Dr. Dickey, we don't want to ever have to consult Dr. Dickey for anything, because the drugs that he's using are for metastatic cancer. Okay, have to be clear that the drugs and the modalities that he's talking about are for people with metastatic disease. That means cancer outside of the prostate that has spread outside of the prostate. We want to detect cancer early enough so that we can use other modalities of treatment that don't have to involve those medical therapies with the risks of those side effects as he talked about. I think it's important to note that prostate cancer is one of the most common types of cancer that affect men in the United States. And the lifetime risk of being diagnosed with prostate cancer is about 11%. And the lifetime risk of dying of prostate cancer is 2.5%. Many men with prostate cancer never experience symptoms, and without screening would never know that they have the disease, because we found in autopsy studies that more than 20% of men aged 50 to 59 had evidence of prostate cancer. They died of something else, but when you look at their prostate, they had prostate cancer. More than 33% of men aged 70 to 79 had prostate cancer that died of something else. So it gives you an idea of how slow prostate cancer can be in terms of growing, which also has informed some of the studies recently about surveillance and detection, looking at the risks and benefits of surveillance and detection. African American men have an increased risk, a lifetime risk of prostate cancer compared to other ethnic groups. So for African American men, it's 4.2%. For Hispanic men, it's 2.9%. For white men, it's 2.3%. And for Asian and Pacific Islander men, it's 2.1%. Let's talk just a little bit about detection. It's an important topic because it is changing as we learn more. The most recent guidelines from the U.S. Preventive Services Task Force came out in 2018. Also, you had guidelines from the American Urological Association that came out around that time. And other groups and other specialties have also, like the American College of Physicians and American College of Family Physicians, have made their recommendations. They don't differ very much. But let me say this, digital rectal exam is not recommended as a screening test for prostate cancer. Okay, it's important to know and understand that, because digital rectal exam has not been found to be effective in detecting prostate cancer. The modality that we use is PSA. That's what we commonly use. An elevated PSA, though, can be caused by a myriad of other things. It can cause by just an enlarged prostate, which we call BPH, benign prostatic hyperplasia. It could be caused by inflammation of the prostate or infection of the prostate. We call that prostatitis. So some men who don't have prostate cancer, hear me, may therefore have a positive test. All right. We call that a false positive test. Men with a positive PSA test result then will usually, based on screening and consultation with your physician, maybe move on to having something as invasive as a prostate biopsy. But I want to talk about that a little bit as well, because I think we have to, because of the false positivity rate that we get with PSAs, it's led to a lot of overdiagnosis, and it's led to a lot of unnecessary procedures that also carry risks. And so the U.S. Preventative Task Force, U.S. Preventive Services Task Force, and others have made recommendations about when certain groups of people should be screened. And I want to talk a little bit about that, because what the goal is try to balance out the risk of causing harm with the risk of actually doing some good and changing the prognosis, detecting the cancer, and preventing deaths. So the goal of screening for prostate cancer is to identify high-risk localized cancer that can be successfully treated, preventing death and sickness associated with advanced or metastatic prostate cancer, which is what Dr. Dickey was talking about in his treatments. Those treatments were for metastatic disease. The most common modalities for treatment of prostate cancer, if you get that far, once you've been diagnosed, is radical prostatectomy, radiation, which is either external beam or brachytherapy, which means you insert radioactive pellets into the prostate, or active surveillance. That's another way to look to treat prostate cancer. Active surveillance basically means that because of the 10-year survival of people who have early prostate cancer, it may not be beneficial to start doing a lot of stuff because we may cause harm. And so because it may not be beneficial to do a lot of stuff because we may cause harm, then just watching the PSA levels and responding if there is an increase or what have you may be the better option. But again, all these options have to be discussed with your urologist, and because these are decisions that have to be made because they are not cut and dried answers to any of this. So I think that's the important thing. So if you're looking for somebody to have a cut and dried kind of cookie cutter answer to prostate cancer detection and treatment, you won't find one as of yet. The most recent guidelines don't give us what the best way is. So it takes a lot of clinical judgment to determine, how you will proceed. Basically, and I don't want to, I don't want to go over my time. There's lots of information here, but in the general population who is not at increased risk, and what I mean by that is people who are not of a certain ethnicity that puts you at increased risk, like African American, or if you don't have a family history, the general population is recommended if you do screening, you do it start at age 55 and you go up to age 69. Okay, it is not recommended that you do prostate screening at age 70 or older. There's lots of reasons for that. It has to do with if you hadn't been diagnosed by now, life expectancy, the risk of treatment at that age, all those sorts of things. Just like I mentioned earlier, a lot of people who are at that age and live 10 or 15 years longer die of something else, even though they may have detectable prostate cancer in their autopsy. So, but we do know that people in the African American community are at increased risk. So that screening recommendation for 55 to 69 is more for people at average risk if we're going to screen. But and they recommend that nobody under 40 gets screened. However, when you look at the African American population, because of the increased risk, you certainly want to screen under the age of 55. And even though there is not any real evidence at this point of how that might help, intuitively we know that if they're at increased risk, then earlier screening than the general population could be useful. As we mentioned, there can be, harms for early detection. The harms of screening for prostate cancer include the harms from the PSA screening test and subsequent harms from diagnosis and treatment. Potential harms of screening include frequent false positive results and psychological harms, and we don't ever think about that. The psychological burden that is placed on those who have to continuously go back and follow their prostate levels and this sort of thing. And and clinically, they may not really be at risk they may not really have prostate cancer, or the cancer is so low level that it's not what's going to take them out. Something else will before then. So the complexity of understanding this is great. So again, that's why I think with your own urologist and you have to make the decision about screening, realizing though that in the real world, when you go out there, a lot of doctors just do it. I mean, they screen, and the PSA comes up a little bit high. They get sent to a urologist, and then they begin to have the conversations. But a lot of times, those people will go on because they feel more comfortable getting a biopsy and those sorts of things. But you have a lot of false positive PSAs with biopsies that are negative. In fact, 2/3 of people with an elevated PSA are found not to have prostate cancer. Okay, 2/3 of people with a negative PSA who go for a biopsy are found not to have prostate cancer. So again, early detection strategies really need to be discussed. And I think this is the take-home point with your clinician, with your physician, because you have to make the decision in conjunction with them of what risks you're willing to take in terms of prostate cancer diagnosis. So I've kind of said a lot, and I don't want to kind of overwhelm. I want to leave room for questions. There's some things that can probably be filled in with questions. So I'll be happy to take questions. Again, I appreciate the opportunity to be here.
Thank you, Dr. Porter. Thank you. That was very informative as well. I have questions myself, so I have to remind myself to bookmark my questions. But thank you. Very, very informative. We are on schedule, so we will definitely have time for questions. More than a few actually than anticipated. So you all definitely make sure that you are dropping your questions in the chat, because it is a lot of information, and I don't want to make it seem like I don't want to overload everyone with the information. So please, please, please make sure that you are keeping track with your questions so that everyone will be able to answer at the end. We're going to move on to our next panelist, who is a survivor of prostate cancer. We have Mr. Larry Wilson. Mr. Lawrence V. Wilson was initiated at Bradley University into Omega Psi Psi Fraternity Incorporated. And please forgive me if I'm mispronouncing things wrong, gentlemen. Have grace on me. But Incorporated Xi Epsilon Chapter. Epsilon. Thank you. Thank you. Epsilon Chapter on April 5th, 1975. He became a charter member of Chi Lambda Lambda Chapter in 2004. He retired from the Illinois State Police Forensic Science Center at Chicago as the acting deputy laboratory director on December 31st, 2017. He was previously under doctor's care for type 2 diabetes, high blood pressure, and high cholesterol. His doctor noticed a prostate-specific antigen, which is the PSA, level above normal 4.50. And on February 1st, 2018, a biopsy on his prostate was performed. During the follow-up visit on February 8th, 2018, it was determined that the PSA level will continue to be monitored. A year later, on February 7th, 2019, Mr. Wilson was diagnosed with prostate cancer with a PSA level of 10. After being offered several treatment and surgery options, he decided to have treatment, which began in March 2019. Mr. Wilson has undergone 2 years of hormone shots, one every 6 months to reduce the size of the prostate, and an 8-week radiation treatment to remove the cancer, which began July 30th and completed on September 25th, 2019. All hormone treatments were completed in October of 2020 last year. And in March 2021, his PSA level was reduced to 0.02. So congratulations, Mr. Wilson, our survivor panelist. Without further ado, gentlemen, I believe we have a few ladies on the call too. Please welcome Mr. Wilson.
Good evening, everyone. Thanks to the Cancer Support Center for having me again. Last year, I did a PSA introduction for the last Leah's cancer program. So this year, I'm pretty much my story. You just practically told most of it, that I had in my, but I would like to just go through, I was going through normal, as you were told, normal type 2 diabetes, high blood pressure and high cholesterol screenings. And I had switched doctors after I retired. So the new doctor asked to, take a PSA level test. And that's again the prostate specific antigen. So my PSA level was about a 5. The normal is 4.5 for my age. It's different levels for your different ages. So since I was so close, we first said, okay, we will just go ahead and monitor. But within a year, it had gone from 5 to 10. So my urologist said, okay, it's time to start treatment. Let's do something about this, because he was concerned. So I was given several options about surgery, and either to remove your prostate, but the things that I heard about surgery and the catheter you had to wear and all that other stuff, and removing the prostate, I didn't want anything cut off on me. So I chose the radiation. And so radiation went pretty well. Like I said, I went through 2 years of hormone shots. You get 1 shot every 6 months, and that's to reduce the size of the prostate. My prostate was enlarged at the time. They did measurements on it, and they told me I had an enlarged process as well. So after I started hormone treatment, because they couldn't start the radiation until your prostate actually gets smaller. So they want to reduce the size of it before they start radiation. And so the radiation was an 8-week program. I had to go 5 days a week. And basically I did it for 8 straight weeks from, like I said, July 30th through, and I completed it September 25th of 2019. So this, I'm really just fresh out of it within the last couple of years. I was at age 64 when I got diagnosed, and I'm currently 67. So, but this radiation was probably the best choice that I made for myself. And it was really easy. Besides just going there 5 days a week, I was only under the radiation for like 10 minutes, or 10 or 15 minutes, so you didn't have to spend no more than a half an hour. And most of that was waiting for your turn. So I was in and out in no time. Some of the other side effects that they were, mentioning earlier, like Rasul was mentioning earlier, you do have a reduced level of sexual activity during when you're going through the treatments and everything. I kind of didn't believe that I would lose interest, but at the time you're thinking about you're getting well and you're not thinking about that, as much. But I will tell you, after treatment and going through my 2 years and everything, everything's like, it's not normal, but my interest has come back, so so you do get that to come back. But I would ask you to make sure that you discuss with your neurologist, how, your life after cancer treatment will be, because I'm sure it's probably different for everybody. And, so that's pretty much my story, so like I said, I started out with Tim when we decided to do something about it with my PSA levels, and now my PSA levels in March was down to 0.02, and I just recently had one in October, and so the PSA level ticked up a little bit. It's now 0.1. So I asked my urologist about that, and basically it's ticking back up because I'm no longer doing anything to reduce the prostate cancer anymore. So, I no longer have any more treatments. But 0.1 is a far different from 4.5. So I'm nowhere near to it coming back and revisiting me. So I'm happy with that. And that's pretty much my story. And if anybody have any questions about, I didn't have all those other side symptoms about, lower activities and things like that. So my prostate cancer was caught early. So, and as he said, the earlier as you screen and get the chance to monitor and take care of it, the better you will survive. And I'd appreciate it. And I'll answer any more questions about it if you have any for me. If not, then that's pretty much the end of my story. Thank you.
We have a couple more minutes for you, Mr. Wilson, so we can actually just for a few minutes, if anyone has any direct questions for Mr. Wilson. I know I have not sort of a direct question, but do you have any encouraging words for folks who may feel nervous or scared to get screened?
Well, there's nothing to the screening part. It usually, you go to the doctor and they'll take blood and urine from you, and then they'll run a test to tell you what your levels are. But as far as the radiation treatment itself, like I said, you're only under radiation for like 10 to 15 minutes, and you don't feel a thing. That whole 8 weeks that I experienced, it didn't stop me, not one, from doing anything that I wanted to do. So my life went on as normal, except for the sexual activity at the time.
And what stage were you diagnosed, Mr. Wilson?
Like I said, it was early detection. So
early.
Yeah. Yeah, I caught it and did something about it early. So I was fortunate.
Wonderful.
So,
okay, I don't believe anyone. If you have any questions, we're gonna any pain or such. Okay, so we do have a Mr. Rashad. Do you want to take yourself off mute? I want to give people the space to ask your own questions. So Rashad, you can take yourself off mute and ask Mr. Wilson your question.
Hey Larry, what's going on? It's Rashad here. My question was, I know you said it was the radiation was, painless and quick. Was not like a side effect. Did you experience any pain during the process to kind of like, going into it, like in your prostate area before or during the treatment?
No, it was pretty much painless. like I said, I didn't feel a thing. I didn't feel anything undergoing radiation. And there was probably one of the side effects is you probably have like maybe more frequent urination, probably feel the urge to urinate a lot. And actually, they did put me on a medication for that, tamsulosin. And that's basically to improve the urine flow so that you're emptying yourself out a lot more. So this actually reduces the number of times that you have to urinate, even though you might feel the urge. But
Did that answer your question fully, Mr. Rashad?
Yes, it did.
Wonderful. Fred, I see you in the chat. We're gonna hold the questions for our doctors and our educator. But I am gonna leave space for you all if you feel comfortable enough to ask your own questions. So that I'm not asking for you, but you all had that direct conversation with our panelists. So just hold on. We have one more panelist, Mr. Dr. Lopez, and we're gonna go right into it. Thank you again, Mr. Wilson, for sharing your story. What an inspiring story. I mean, just for you to be 2 years out, you look good, sound great. And again, thank you for being here to share this space with everyone tonight. We're gonna go into, last but not least, our health educator on the panel tonight, Dr. Eduardo Lopez. Dr. Eduardo Lopez is a bilingual English-Spanish health educator who currently serves as an independent contractor. Dr. Lopez holds 25 years of experience as a health educator, and 18 of those current years he has been with Aunt Martha's. Dr. Lopez is married to a beautiful wife and had previous experience servicing organizations such as the American Red Cross, YME organization around breast cancer, and Dr. Lopez, I'm going to let you pronounce because I don't want to mess this up. The last one, the medicina. Can you pronounce that?
Sure. Oswaldo Lopez is fine. I'll go for Ozzy. It's easier to remember. So you can call me Ozzy. Well, thank you. First of all, thank you for having me. It's a pleasure being with you. Such a great panelist along. I don't know if I can top that off because they're so knowledgeable. So I'm going to share with you what I do have, okay? So I'm going to start sharing my screen with you. Let me know you can see it.
Hold on one second, Mr. Lopez. Let me make you a co-host.
Co-host, okay. Yeah, I do work for Marta's. I'm a health educator. I do provide health education to all certain topics, not only health. Pretty much go around the communities. I travel statewide. I'm not limited to one location or one organization only. I do work with different a variety of people in settings. I can do health fairs. I do schools. I do community centers. I'm pretty much whatever I'm needed because I do believe I'm a doctor. I'm a medical doctor, but I do believe in prevention. I truly believe that a key word in here is prevention. Okay. So let me see if I can share with you my screen. Perfect. So let me know you can see that. I'm in a few words. I always say that a picture says more than 1,000 words, right? So first of all, we need to know what prostate cancer is. And prostate cancer is cancer that occurs in the prostate, and the prostate is a gland that is located in. You can see in the picture, it's very close to the bladder. And for those who ever wondered what it was, prostate cancer is one of the most common types of cancer, especially in men. This type of cancer does not discriminate. It doesn't go for age or race or gender or sexual orientation. As long as you're a male and you're a prostate, you are at risk of having prostate cancer. Pretty much I can say that. Symptoms of prostate cancer. This is something very important that we cover because there are not specific symptoms that we can say a person who had prostate cancer or benign prostate dysplasia can have. But the most common ones that we can mention will be an increased urination at night that we call anicturia. Sometimes difficulty starting and maintaining a steady stream of urine. Many times blood in the urine, painful urination, sexual dysfunction. Sometimes person will come to the doctor because of the bone pain, or many times it's the stinging, the leg weakness, and urinary and fecal incontinence. So those are the most common symptoms. They're not particularly for prostate cancer, because these symptoms can be a part of any other condition as well. So importantly, I say prostate cancer can be prevented. It is something that if you are assertive and you are interested in, talk to your doctor. When do you see a doctor? Well, make an appointment as soon as you think that you might consider having any symptoms, or you might be concerned about your prostate. What age is that? I will say at any age. But most likely, people will recommend start prostate cancer screening after 40 years of age. If you're a high-risk population, let's say there's some cancer family history, you consider high risk, then I would say 45 years of age, you can start the PSA on the digital exam. If the general population, we do recommend after 50 or 55 years of age. Again, this is it's not a rule. We can say, well, I'm not 40, I'm not 45, I'm not 50, I'm not gonna go. No, it's not a rule. As long as you do have a concern, as long as you have a question, you can always go to your doctor and you can get an exam performed. Now, what causes prostate cancer? Risk factors are obesity, age, and a family history. Prostate cancer is rare in men under the age of 45, but it can be present, but becomes more common with advancing age. Genetic plays a huge role in it, because if you have a family history of cancer, not only prostate, but any cancer in the family, you're considered high risk. And also something that we have considered and important to talk about, especially since we have a pharmacist with us, as medication exposure. Drugs, medical procedures, and medical conditions also have some links with prostate cancer. And sexual factors and other factors. Some studies show that having many lifelong couples or starting sexual activity early in life can increase risk. Yeah, saying in medicine that it says an organ that is not being used can be wasted or can disappear, and an organ that is being overused can overgrow. And when we say overgrow, we're pretty much saying about cancer. What are the risk factors for prostate cancer? Well, older age. Your risk of prostate cancer increases as you age. It's most common after age 50. Race. For reasons not determined yet, Black people have a greater risk of prostate cancer than do people of other races. In Black people, prostate cancer is most likely to be aggressive or advanced. Another risk factor is family history. As I've mentioned it before, if you have any family history of cancer, you consider obesity. People who are obese may have a high risk of prostate cancer compared with people considered to have a healthy weight. So directly, I do not know the factors causing that, but it's considered a risk factor. Now, speaking of prostate cancer, it's also a taboo or a stigma. Doesn't matter what age, what race, or what gender you are. Just talking about cancer per se, it's difficult. Many times people have a tendency not to talk about it, thinking if I don't talk about it, it's not going to happen to me. But it can happen to all of us, especially you're a male. Now, it is important because this cancer can be prevented. You can do something in order to avoid having it. So there's some things that you can do, as a prevention. You can choose a healthy diet full of fruits and vegetables. Choose healthy foods over supplements. Exercise has to do a lot, not only with your heart, but also preventing cancer. Maintaining a healthy weight, since obesity is a link factor for prostate cancer. And speaking to your doctor, especially if you have any about cancer or prostate cancer or any type of cancer, he or she is the right person to speak with. Now, how do we do a diagnosis on prostate cancer? Well, we do a PSA and a digital rectal exam. What is the PSA test? So PSA stands for prostate specific antigen. It's a protein produced by normal as well as malignant cells of the prostate gland. The PSA test measures the level of PSA in a man's blood. For this test, a blood sample is sent to a laboratory for analysis. The results are usually reported in nanograms, and Mr. Larry can specifically tell you more, because I'm pretty sure he's a pro right now about having the results for a PSA. Now, we do recommend not only having a PSI, but also a digital rectal exam. During a digital rectal exam, your doctor inserts a glove, lubricated finger into your rectum, and feels the back of the wall prostate, gland for enlargement, tenderness, lumps, or hard spots. Usually, this test is what scares most of the men. Not the PSA, no. You can talk to them about PSA, but unfortunately, a PSA is not good enough for us to diagnose or eliminate prostate cancer. A digital rectal exam is necessary, and this is when the problems come, especially among men. So what is important screening for prostate cancer? Well, as to having an early detection diagnosis, it reduces the death from prostate cancer in men, and actually offers you more opportunities to have different treatments. I usually do not talk about treatment for prostate cancer or any sort of chronic diseases, because every treatment is unique. Even though it might be the same medication Dr. Lopez uses, or the same medication that Dr. Wilson's or Dr. Patel uses, it does not affect the same. So those are very unique for every person. And this is, I usually stay away from it because many people have many different reactions. It's nice to know the side effects, but not all of them have them. And most likely it is more important to know that you have what you have and what you can do to treat it. Those are the things that we talk about, especially among men. And as I say, this is very common. Prostate cancer, it's with us, it's among us, and it's affecting us, especially you're a male. Any questions?
Yeah, we can open it up for questions. Now, thank you, Dr. Lopez, or Mr. Lopez, for just taking us back to the basics. I think it's really important for folks to know the basics and general information of prostate and why it's important for folks to be proactive about their health. So thank you, Dr. Lopez. We can definitely open it up for questions now. The way I'm going to do this, folks, is just sort of go back to the beginning and go in the order in which it was asked. And then once we go through the questions that were in the chat, folks can ask additional questions. We're going to do that for about 10, 15 minutes. So the first question was asked by, it looks like, Dana, is it? Do we still have Dana on the line? So the question, I'll ask the question so we can keep it moving. It says, please explain PSA and how frequently should one get PSA? Does it replace digital exam? I believe one of the doctors touched on this briefly, but it is worth repeating. So either of you all can answer that question.
So according to the guidelines of American Urological Association, U.S. Preventive Services Task Force, no more than they're thinking every 2 years to screen. I think that was part of the question that he asked. Not yearly screening. Okay, I mean these are the updated recommendations. And also, I know Dr. Lopez had in his exam the importance of digital rectal exam, but the evidence shows in multiple position papers that it's not useful. So that's helpful because digital rectal exam does scare a lot of people away from getting prostate screening. And so finding and understanding that the recommendation now is clearly and documented not to have a digital, not recommended to have a digital rectal exam, I think is an important one.
Righty, anyone want to add to that, or are we good to move on? All right. Rashad, you had a question for Dr. Dickey in terms of if there's a specific modification you want to ask your question.
Yes, Brother Dickey, you did mention a lot of medications. I know we don't want to go that route, but in your experience, is it a specific medication that you will warn men to make it as their avoid if necessary, if they do have to go that route, the one that's got the most likely to have a negative side effects on you?
Well, I'll say it's not really a medication that I would tell people to avoid because unfortunately with cancers, depending on what degree they, that their score came back, whatever. And I know Dr. Porter or Dr. Lopez can probably speak to this. You don't really have much choice sometimes in some of the therapies. So most of the medications that I deal with, like Dr. Porter said, people are already, kind of far gone and it's metastasized. So you don't really have too much of a choice. So we try to be pretty aggressive with our treatment here. So really, we're more about trying to make sure that we can, treat you aggressively and still have a good quality of life. But by the time you get to me, like you were saying, you need certain therapies to treat you a little bit better.
Thank you.
Awesome. Richard Brown, do we have Richard Brown still on? I believe there was a general question for all of the panelists. Richard Brown.
Yes, I'm still here. How's everyone doing this evening? And Dr. Porter actually kind of spoke to that in regards to a specific age. And the reason I'm asking, I do have a history of, prostate cancer. My father's younger brother passed away at a fairly young age, and he was a athletic build, in shape type gentleman, and so it kind of raised concerns. And for me, and my father had been directing me to see when is a good time or to start getting that tested with the family history, and so that's what posed the question.
If I can say yes, you are considered to be a high risk patient. So my recommendation and the recommendation would be over 45 years of age. But again, there's no against doing it, even if you're younger than 40, 35, as a recommendation just to do that, a PSA. It's recommended.
Appreciate it.
Yeah, I think, and here's the art of medicine. It's the complexity of trying to, when you don't have in front of you like a formula for everybody, you really have to have a physician that you trust to help you make these decisions. One of the things that I recommend is, for instance, the age that your uncle was diagnosed with prostate cancer. I don't know what that is, but if it's possible to start at least 5 years or so before he was diagnosed, that's kind of a rule of thumb that I use. In colon cancers, for instance, and people who have family histories, who have familial polyposis syndrome and those sorts of things, they get screened, but at the age that their first degree relative was diagnosed, they get screened at several years before that. That's how they begin screening. So I've just kind of translocated that into thinking about prostate cancer as well, because there's not any specific answer for that. But we know that that in general, the recommendation is not to screen below the age of 40, but there are people who below the age of 40 have died of prostate cancer as well. Okay, I mean, it's not common, but it happens. So if you've got a family history, if it's possible to back up a few years before your relative was diagnosed with prostate cancer, that's when I would start. You know, if you have the luxury of doing that. But if not, if you're already, of course, at the age, if you're already, I'd say in your case over 40, go ahead and get started.
Appreciate it.
I actually have a question. We have a few more questions, but I'm so glad you mentioned, Dr. Porter, the trust of having that trust with your primary, because I know a lot of times with both men and women, especially African American community, it's hard for us to trust physicians. And so I have a question I want to pose sort of to all of our panelists. And Mr. Wilson, you can kind of give some input on it as well in your relationship with your primary. But for those who have not reached the neurologist part yet, what sort of some things that patients, or that we should be looking for, that men should be looking for with their primary doctors, as far as early detection and screening? Like, what are some of those conversations should entail around? Because a lot of times men may not know the questions to ask. So what are some ways they can be building around those conversations with their primaries?
So, and I just want to be clear. I know it's probably a slip of the tongue, but I don't want anybody to be confused. It's urologist, not neurologist, because I don't want anybody going to see their neurologist for a prostate issue.
Lord help me. Thank you.
That's okay. I just want to make sure that we're all on the same page.
Thank you.
Yeah. So you know, the important thing is that you got to have a physician who cares about you. And you can usually sense that on the first couple of visits, whether they care about you and the time that they spend with you asking you pertinent questions, okay? Because sometimes we don't know the questions to ask, but the physician should know the questions to ask you based on who you are, your risk of certain types of cancers, etc. They should know the questions to ask you. More and more, I have to say and admit, in this day and age where insurance companies run medicine, where physicians have less and less time to spend with you, they really have to digest down and get to the nuts and bolts of those important specific questions, because they don't have a lot of time to spend with you anymore. I mean, that's just being honest about it. However, if their physician is not asking you those questions, you know, you need to be concerned. And unfortunately, there are a lot of physicians who are not asking those questions that are you know you're in and out real quick, but none of the most of the diagnosis that happens doesn't happen on exam. It happens in the history and physical, meaning I can come to a diagnosis most of the time based on what you're telling me, as opposed to even having to examine you. So talking and asking questions is an important part of how we are able to make diagnosis and how we're able to make recommendations to our patients. So I just challenge you to find that physician that you can have that rapport with. And it doesn't hurt to also, on the other hand, educate yourself, because sometimes if you get into that physician's office that's really busy and they don't ask you the right questions, you can help them. You can steer them and help them to get to focus in on what's important in terms of your health and cancer screening, etc. Because you've been educated and you know. It doesn't mean the physician doesn't know anything. It just means that the physician is so hurried right now that they're not taking the time to ask those questions. But you being proactive and learning about your own health and knowing, going in what questions to ask is going to be really important in helping that equation.
Let me second on that, Dr. Porter. It is true what you're saying. It's so important that you don't, doctors want patients to be more assertive and more active into their care versus just coming here and listen to what I have to tell you and go home. No, they want you to be active about what's happening to you. And a doctor whose patient is asking question, it creates more of a bond. Finding a good doctor is finding like a good husband. Once you find one, marry him. Honestly, that's my word. They're so difficult, but you have to be active. Be proactive, not reactive. As a patient, you are allowed to ask questions as a patient because it's your body. It's you who we are treating. We are treating you. We are not treating ourselves. We are treating you. So we need to know what's going on with you. Don't be passive. Be more assertive and more active about your health care.
Thank you. We have a few more questions. We got a couple more minutes for a few more questions, and then we're gonna close out our discussion. So, Fred Arnold, are you still on the line? Still on the call? You had a question. I believe it's a general question for our panelists. Fred? Okay, so the question is, what are the signs of an enlarged prostate? And either panelist can answer this.
Sometimes nothing. Sometimes you have urinary symptoms. As mentioned earlier, I think Dr. Lopez mentioned in his presentation about urinary frequency, change in urinary stream, feeling that your bladder is incompletely voiding, like you go urinate, but then you still feel like after that you still got more to come out. Those things are symptoms of a prostate that is putting pressure around the urethra, and so you're not fully emptying your bladder. Now that can also be caused by just benign prostatic enlargement, but it can also be caused by prostate cancer. In advanced stages of cancer, you can have other symptoms like strange pains, back pain specifically. You can have leg pain, which might indicate that cancer has spread to the bone or spread around the spine and cause problems with the nerve. So, back pain that's unexplained needs to be investigated and not just kind of put off. Sometimes we can look at the history and we can say, okay, well, you pulled your back last, so your back's hurting now. You may have pulled your back last week when you told me you did this thing, so we can watch it. But if back pain lasts and doesn't go away, you need to be checked more thoroughly to make sure there's not something else going on. So those are some of the symptoms. But by and large, as I mentioned earlier, those 30% of 70 to 80-year-olds at autopsy had no symptoms, and those who were younger than that 20-something percent, 50 to 59, had no symptoms either. So hence the importance of screening and early detection. Just like you may have no symptoms of colon cancer at all, but it could still be there, and that's why we are very proactive in doing that, because we know we can prevent any further issues.
Yeah, unfortunately, there are no specific symptoms for either prostate cancer or enlarged prostate. Like Dr. Porter mentioned, it's many times a diagnosis is coming because the patient is coming for one reason, and then suddenly you find prostate cancer in the person. And it happens. It happens very often, more than what you think it happens. So again, there's no specific symptoms for it. Just be on the lookout for any symptoms you might have.
Mr. Wilson, did you?
I was just gonna say that was pretty much what was happening with me. I was being screened for other things
right before, but
I actually changed doctors after I retired, and so the new doctor that was starting to ask me more questions about my health, how I was feeling, and he wanted to make sure that I had a total screening just to see what was going on with me, and that's why he started the PSA test with me. Because I don't remember the doctor that I had before that ever having a discussion about my PSA levels, and it was like the first time I was with him, and he had me take a PSA test, and then he said it was above normal, but I mean, I wasn't actually feeling anything different, so and to me, the whole time that I went through treatments and everything, body-wise, I never felt anything different. The only times there was, I think I got asked about pains. The only pain I did have the digital rectal exam, and that was painful, and the biopsy was painful. So those are the only two things that I experienced pain with.
Well, thank you, Mr. Wilson, for sharing with us, because it really takes a lot for a person to share a personal life experience such as yours. And this is a living proof that this is happening. And as it happened to Mr. Wilson, luckily he was able to found his prostate cancer in the early stages, and he was lucky to get a treatment, and he's been lucky to be having a healthy life. And this could be you. This is our message to you. Do not wait until it's too late. Do not wait until the symptoms appear. And you think you are at an age for screening, and you do have a question or a doubt about it, just go ahead and do it. Don't hesitate. Again, be proactive, and thank you, Mr. Wilson. That's really, really wonderful having you and sharing with you this panel.
Absolutely. Absolutely. Okay, gentlemen, 2 more questions and then we're gonna go ahead and close out. We had a few more, but they were all pretty similar to what has already been asked. So the first question is for Mr. Wilson. And it is, did you partake in any other types of medical treatment, specifically alternative holistic support?
No, I didn't. I didn't partake in any holistic, alternatives at all. So, but I chose not to have surgery. That's I didn't want anything cut on me. So that was why I chose the radiation route. And I'm so glad I did.
And then the last question, I believe it's for Mr. Lopez, but any of you can answer this. And it states, besides a proper diet, are there any preventative supplements?
Well, I don't know if you ever heard this saying that is, you are what you eat, and it's absolutely true. The healthier that you eat, the healthier that you are. I mean, there's so many nowadays. There's so much accessibility that you do have through the internet and technology. I remember 20 years ago, I would never even dream of having this presentation right now, or not or less, being able to Google something, a symptom or anything, or a specific diet. Now, there's so many things out there, but you have to be careful, because in the healthcare system, it's a puzzle. The doctor, your pharmacist, your X-ray technician, your nutritionist, your radiologist, your oncologist, every one of them are very important. They're not separate. We are one entity. I cannot perform without my pharmacist. My pharmacist cannot perform without my nurse. My nurse cannot perform without my X-ray technician. So we all part of it. And going back to the original question, there's so many things available for you. All that you have to do is ask, and we can point you to the right direction, definitely.
And that is so well said. Anyone would like to add on to that? All right. Well, again, thank you to each of our panelists. You all have gave such informative, critical information for all of our guests to take away. I know I learned a lot myself. So again, thank each of you for your time and just giving us this needed information. I want to thank Chi Lambda Lambda Omega Fraternity, Omega Psi Fraternity, forgive me, for this partnering with and just setting this space for folks to join. Prostate is a thing we have to be proactive about year round, not just in November, not just Prostate Cancer Awareness Month, but year round. And so I want to leave a few minutes for Mr. Stalling to give a few closing remarks, and we'll close right on out.
Thank you, Shemaya. Again, want to thank everyone for joining us tonight. I want to thank the Cancer Support Center. We've partnered with them for the last couple of years on breast cancer awareness as well as prostate cancer with their Kick It Cancer initiative, and very glad to do that. I want to recognize a couple of people. First, we have our first Vice District Representative on the call, Brother Sean Long. I want to thank you for joining. Want to thank our 10th District Health Initiatives Chair, Brother Dana O'Bannon, for joining us tonight as well. I want to thank Chi Lambda Lambda, our executive board that's here on the call as well, Brother Boslis, Brother James McGee, Brother Vice Boslis, Rashad Nuruddin, Brother KRS, Carl Bryant, and Brother KF, Sean Brown. So again, I want to thank everyone for joining us this evening. Hope you got some good information. I want to thank our panelists. Dr. Lopez, thank you. Very good information. Really appreciate that. For our doctor brothers, Dr. Fulton Porter, Dr. Rasul Dickey, I called them up, asked if they want to participate. And they've participated in the past on other panels and are always willing to express and give that knowledge and information because it's something very important in our community as far as making sure that we are, again, preventative so we don't have to go into certain situations. I want to thank Brother Larry Wilson for sharing your testimony and your story. Really appreciate that information. And again, as just letting people know that you just never know. So it's always good to, again, ask the right questions, find that right doctor that's in your corner to work with you so that you can get some things taken care of before they get out of control. So this being our Achievement Week, one of our Achievement Week activities, again, our goal was to have at least 40 people to participate, and I believe we hit our goal, even though I did see a couple of people had their names on there twice, but I'm counting you anyway. Tomorrow is our Founders Day, 110 years for this great fraternity, Omega Psi Phi fraternity. And we will have additional luncheon tomorrow from 11 to 5, I believe, in Markham. So we can look out for that information. It's been sent out to the chapter. If anybody else wants additional information, we can get that out to you. Also, yesterday, we started our chapter fundraiser for Spanky Gourmet Pickles. So look for information on that. That is running from November 15th through the 30th, not the 31st. And that pretty much concludes. And again, want to thank the Cancer Support Center. It's been a great partnership. And again, thank everyone for joining us today. Shemaya.
Thank you all. Kathleen did drop a screening pledge that the Kick It Cancer Initiative has rolled out. So you all heard all the great information about screening. We encourage you all to take the digital pledge to get screened within the next year if you haven't done so already recently. And the center is here. We have all sorts of great resources for those who may have a diagnosis of prostate, but not just prostate, any cancer. So I just wouldn't leave you all with encouragement to take the pledge and go to the center's website to see all the great resources we have for cancer patients. Thank you all again, and I hope you all enjoy the rest of your evening. Bye, everyone.
Thank you very much too, Ms. Bird.
Thank you.
All right.